Good morning, everyone. This is Kristy. It is Sunday morning and I'm getting ready to go to a conference. I have to keep up with my certified association executive credits. And so we have a conference that I registered 4 months ago thinking, there's nothing going on in April. It'll be great. So this is a message because I literally can't write this out. I have officially transitioned from a writer to a speaker. My speaking skills are still lacking. So family medicine residency colleagues, I am so pleased with how things went on Friday. It was so great to have Brooke and Becca in the area. We spent Thursday, well, actually they came in Wednesday and had dinner with Dr. Mitchell, looking at the Yuba City locations of Ampla Health and just sort of getting a sense of that area. And I say this only because Yuba City is a key part of our psychiatry residency. They are in the main location, for lack of better words, in the moment for the child and adolescent psychiatry rotations. And Ampla Health as well. And Ampla does want to be a partner in the family medicine residency. So it's worth knowing the geographic area for somebody who's not from the area. So Brooke and Becca then spent Thursday driving around with me and Lena and Sana. We were able to go into Paradise, over to Oroville, and then down to Gridley. Sort of getting a sense of how all of that relates to Chico and Enloe Medical Center as the primary hospital for family medicine. And then on Friday morning, they went over to Willows and met with Dr. Joanne Reed of the Rural Health Clinic there, and plenty of volume. They are really an essential, critical service for the community, really, in Willows. So that was really great. Thank you for heading over there early in the morning on Friday, Brooke and Becca. Then they went over to Mission Ranch. I said, we're having this problem getting the continuity clinic together, but Mission Ranch does have enough doctors and enough volume. So they went over and they dropped Dr. Nelson's name, and they got in and got to see around that clinic. And then we met at 10:30. Dr. Mairano brought us around the hospital. It's such a great hospital. And then we, of course, had the GME Summit. We had a very interesting conversation with Dr. Mairano, and I just want to reflect on it here in this video because I'm really torn. I'm not torn. I'm dedicated 100% to one effort and 100% to another effort. And of course, we all know that doesn't lead up to 100%. So hear me out. And I don't know if I can be in any of the meetings this week. I'm going to this conference. CMA's Advocacy Day is on Wednesday at the Capitol, which is an all-day thing. And then Thursday, I head out to a workshop that I planned to go to. So this video will have to suffice. Okay, so, we have 100% commitment to Enloe Medical Center and making sure that Enloe steps into this GME space as fully and completely as they can, given all of the CMS reimbursement guidelines. We're very positive about their financials, given the CMS reimbursement rate that they're able to draw down. 75% of their patient population is Medi-Cal, Medicare. So wow, perfect partner. And I just want to say there are so many people who have said to me, why isn't Enloe doing GME? And this is far beyond the medical community in Chico and Butte County. This is people at the state and federal level that know about Enloe Medical Center and want to see medical education there. So this is absolutely something that we're excited about and dedicated to. And I'm very, very pleased that Partnership Health Plan has agreed to sponsor. We're working on the paperwork with them. The sponsorship monies will come to Healthy Rural California, and then we will be able to pay for the the actual initial feasibility evaluation of Enloe Medical Center to see all of the graduate medical education opportunities that would be available to them. So that's in the works. That's fantastic. And I think that shows our dedication to making sure that Enloe Medical Center becomes a teaching hospital in the best way possible. And however our partnership with Healthy Rural California can progress is wonderful. The family medicine residency was that first step. And in some ways, I can look back and think, gosh, maybe we should have started with internal medicine for Enloe. But knowing now how many doctors are IM versus FM and all that stuff. So, but it's okay because we have so much of the family medicine residency wrapped up with Enloe. It's fantastic. And there's just some final bits, and that Healthy Rural California has this $2 million grant from the state, which went into effect in March, to launch a family medicine residency. And therefore, I believe there could be some funds that we could allocate to Enloe to do the things that we were talking about Friday in terms of getting their primary care clinic situated so that it can be that continuity clinic. And then all of the CMS reimbursement rates are within Enloe and makes the most financial sense for Enloe Medical Center. So fantastic, 100% committed to that. Would love to see the primary clinic for Enloe grow. I think that between Enloe's reputation as the best care provider in the community, and then several primary care clinics faltering, doctors retiring and moving out of the area, things like that, having a hard time recruiting physicians to the area. Very, very challenging situation. And so we would want to see Enloe's primary care clinic succeed as well. So I'm not sure about that funding. I have emailed Callie and Rachel to see what might be possible in terms of monies that we can give to Enloe from this grant to establish the family medicine residency. And that might not be details that we can give just yet. It's just a brand new grant. And then there's all this other stuff that I'm going to articulate in this video so that you all understand where I'm coming from. So the psychiatry residency and the funding with Butte County Behavioral Health is this whole other thing. I'm actually going to record a second video once I'm done with this one. And that's purely for Butte County and then the state, the HCI department, and that $1.8 million award that we got in 2020 before any of us knew anything. And there's just some language and understanding of the ACGME accreditation process that is just nobody knows, right? Like, unless you've actually done what we've been doing with the psychiatry residency or you're a consultant, you don't really know all of these steps. It's very complex, lengthy, expensive, costly process. And but I wanted to state that because of that conversation that I'm having with Butte County Behavioral Health and they are having with the state for that one award, it made me look at our award for the family medicine residency from HCI that we just went into effect in March. And, you know, honestly, the end result is accreditation. So I'm going to be having these conversations about the psychiatry residency, and that yes, initial accreditation is a huge, is like the milestone that everybody should aim for, because you can't do a residency program without ACGME's accreditation. And yet there's so many more expenses beyond accreditation. It's actually initial accreditation. And you're really only in this application for family medicine putting down maybe 90%, 95%, maybe even 80% of the total curriculum. And then that is enough for ACGME to say, okay, yes, you are initially accredited. And then initial accreditation is that step that's needed in order to recruit residents, to get into their system, to join ERAS and the whole match day process, which opens up in September of every year. So my point in telling you all of this is that I don't think we should rush to meet any deadlines at this time, because if this, and I have the printout right here, that's why I'm like pointing to it. If the family medicine residency is only through accreditation, and we're not looking to have our residents start until 2025, from a funding perspective, we are shooting ourselves in the foot to get accreditation in late 2023 or early 2024. We will literally not have funds to go from initial accreditation to having the residents start. I won't be able to pay Dr. Zwerdling as DIO for this work. I won't be able to pay Dr. Schroll as the PD for this work. I won't be able to pay our staff. If the state is saying that accreditation is the final point of this money, we will not be able to claim expenses beyond initial accreditation. And I know that's a really strange thing, and I'm really hopeful with the psychiatry residency that I can argue the point that, yes, initial accreditation is important, but there's still a huge amount of money needed to get to when the first cohort of residents start, and we can draw down the funding from the federal government, whether it's teaching health center funding or CMS reimbursement rates. And in fact, with CMS reimbursement rates, you have the first half of that first year, the half of that first year where we will be paying the residents, but the CMS reimbursement rates are for reimbursement, so they don't kick in. And so there's no funding through the first half of the cohort starting. So this is my message about where we are right now. I also think that we have to take some more time. So I'd like to bump our final date, the deadline that we're aiming for, to get PLAs signed and everybody on board and the faculty on board. I'd like to bump that to May or June. I'm sorry, from May to June, maybe even into July. And the reason is partially because on Friday afternoon, we did this big call out for faculty. We have a large number of CVs that have not yet been received. There's going to be some work needed to tease that out. We have the quality improvement symposium at NLO in May, mid-May. And so I think it's okay. I think we're okay if we just go a little bit further into making this the strongest application we possibly can. And allowing NLO Medical Center to take the steps it needs to do, everything. I'm not saying that their initial feasibility evaluation would be needed to be done before we finalize the family medicine curriculum, but I could tell that there were some things they need to kind of line up. So if in fact, this particular application that we're talking about right here, right now with Brooke and Becca is 100% at NLO Medical Center, and the continuity clinic needs to be beefed up a little bit. There's just some things that we have to put in place before we can actually wrap up, finalize this application and the program letters of agreements. We're so close. We're so close. And I really do actually feel we could make it work in May. We're so close. However, I'm in no rush to get accreditation if in fact the state will not give us funding beyond initial accreditation. So in this moment, the decisions that we have to make are truly around the curriculum. And I'd like to give that a little bit more time. I think also that we have to recognize that word of mouth is going to be necessary, that there's from a physician at NLO Medical Center to be excited and say, yes, we're committed to this. to actually getting their CV to us and us working with them and teasing out their scholarly activity, providing more faculty development from day one. All of that is just not going to happen by early May. That's okay. And it's okay. Literally, our funding, we don't want to get accredited too early and then not be able to draw down our state funds. This is a $2 million grant, and we want to make sure that we're utilizing that as best we can, even to support Enloe Medical Center and making sure that their facilities are what ACGME would be looking for. So all of those details have to be worked out. I also really do want to take the time to get our business agreement together. And there's some calculations around what, right, how much of these expenses will Healthy Rural California need to ask of Enloe Medical Center, and put those in and have their lawyers look at it and have our lawyer review it. And I've learned my lesson in the past, which is to rush those agreements. Business agreements means that details get missed. And I don't want that to happen with our partnership. This partnership means more to me than just a business agreement in place. We do know, and I'll speak to this, we do know that there's a minimum of $160,000 a year that we need per resident. However, when I'm looking at all of the federal teaching health center advocacy paperwork and all of that, they're basically saying $210,000 per year is a more realistic cost analysis. And so then we have to look at what our particular needs are within that range. So lots to figure out. And I just want us all to take a deep breath and know that it's okay to be delayed. In fact, it's probably best for our funding. The last bit that I wanted to talk about was in a reflection of all of these conversations that we've had in the last couple of days, and that we are actually moving away from our original intent of this family medicine residency program. And I think that it's Dr. Mitchell that best describes what we would like to see. And that does not negate this effort for Enloe Medical Center to become a teaching hospital, to have its full complement of residents, and to be able to draw down and benefit from all of its CMS reimbursement rates for the entire family medicine residency. So that is what Brooke and Becca are advising Dr. Mairano, which is as much as we can contain at Enloe, the better. This is also true for Enloe's effort to have their maximum complement of all graduate medical education within the 5 years of the cap, which is also another reason to delay our application. Take our time. Take a breath, take our time with this application to ACGME. And that is that the minute the first family medicine residents step into Enloe, that's when their cap gets triggered. And so if they're going to be committing to this, meeting that 5-year cap at maximum capacity, waiting one more year till 2025 for the family medicine residents to start, actually helps that goal. Okay, but back to this other goal, this other 100% commitment in my heart, which is to establish a rural residency for family medicine, to really partner with Northern Valley Indian Health and the VA. There's all these other partners that when you say we're committing to Enloe 100% for the family medicine residency, that means that all these other partners that we value and have good teaching, great faculty and a wonderful learning environment for the residents, a really innovative curriculum that is just really going to shine and support all of the clinics in the area. That's a very different residency program than what Brooke and Becca are guiding us through with Enloe. That's okay. I just have to articulate this tension that I've been feeling, because both paths are viable. Now we have a federal grant, and I'm sure you've already heard this, but I'm just going to say it again and just remind everybody. We have a HRSA grant to launch a family medicine residency. And that was the first grant that we got. And so it is what we entered into all of these conversations with. And it dictates that we have to have more than 50% of the clinical facilities for this family medicine residency to be located in rural designated areas. And that would not be Chico. When you look at mirural.org or Google MI Rural and go through those websites, they will show that Enloe Medical Center has no rural designation whatsoever in the world. There's a possibility we could look at them as a GME naive hospital, then triggering that rural designation. But I would posit for this team to really discuss a second family medicine residency that would be rural. And it could just be 2 residents to start with, right? We now have a lower threshold to start. It could be that it's at UC Davis in Sacramento the first year. And it could be that we're not actually submitting that application until that cohort would start in 2026. So if that cohort starts in 2026, that gives us more time to define these clinics, but it also gives these clinics a chance to get more family medicine docs on board. Here's the dilemma. So we had a really great conversation with Dr. Natalie Ledeen. She's at Orchard Hospital. She's their CMO. She is a force to be reckoned with. It's fantastic. She's literally recruited all of these doctors to work at Orchard. And it is possible they're all like relocating to Chico. There's actually this small group of doctors related to Orchard Hospital, like migrating to the area. And we want to have the doctors in the clinics, not sort of flying back and forth between, Southern California and Chico. So this is great. It's a great movement. She's also talking about how those doctors might have different affiliations, sort of like with Northern Valley Indian Health, or, maybe helping Northern Valley Indian Health recruit family medicine doctors. We want a family medicine residency that has tribal health as a key component of the curriculum. We want to help and have residents going to Dr. Joanne Reed in Willows for pediatrics. They have the volume. They have 100 patients a day. It's an enormous service to that community. We want doctors to go to Paradise to serve that community. Our initial founding for all of this work is based on the fact that the campfire happened. People are moving back to Paradise, and there are some fantastic facilities with Paradise Medical Group, and the Adventist Health Clinic there is really nice. I mean, there's these nice buildings, which is kind of sometimes the opposite, where you might have the doctors but not a nice facility. But when you look at it through the lens of residents coming to the area, great facilities, but let's maybe give them a chance to recruit the doctors to work in that. And I get it. All of you are probably like, Kristy, please don't say this, but I am committed to having a rural residency with these outlying clinics that are needing to benefit from residents coming to the community. So I don't know how y'all are going to talk about it, and I'm probably not going to be in any of the meetings this week. That's okay. But we really do need to either, go 100% Enloe, and that's the end. We need to, Rachel as well, get back with Dr. Epstein so that I can have that conversation with you all, with Dr. Epstein. That's the family medicine residency, HRSA grant TA, who's a fantastic human being. But we also need to know that Enloe's committed down to this, what I would say the 100% Enloe family medicine residency pathway before we have that conversation with Dr. Epstein sometime in May. Because the need to have the residents go beyond the borders of Enloe is great. And I think that there's ways that we can make this happen while still committing to Enloe's need to step into the GME space as fully as possible beyond the family medicine residency, but also that the family medicine residency within Enloe, 100% CMS reimbursement rates for Enloe makes sense and is viable. We're almost there. So I thank you for listening to my statements. I think we have done amazing work. I do believe we could put something together by early May and have a fantastic application, but I just think there's these other things to consider, especially the fact that we have funding. And then I need to now record a second video, and I'll consider sharing it with you all just so that you can understand. Funding is fun, but we put the fun in funding. Just it's not fun. It is causing me hypertension, literally. I am struggling with hypertension. So, and it's not just my personality. Okay, so I'm going to wrap this one up, and I'm going to record the psychiatry one. And again, it's all funding related, and the fact that there's such great will, and I'm so grateful that California has put forward all of this funding to help establish new residency programs, especially in rural areas. But the arguments are, there's just, I'm sorry, education, not arguments. It's information and education. All right, you all have a great weekend, and I will be seeing you soon.